If yes, let the go ahead and share anything.
Wanda ya kama ne jiya a daidai lokacin da Allah shanye a nan take na shanye sa.
So please, who is expected to share the slides?
Tsarikaten Allah shi.
Who's supposed to share the slides?
Okay. Good morning. Good afternoon, sir. Good evening. Which topic are we doing today?
What we have left, we have not taken pneumonia.
Okay.
So let's start with the pneumonia.
Okay.
Yeah. So today we are going to discuss pneumonia. And like we mentioned previously, pneumonia is one of the common causes of under 5 deaths, and all the other causes of under 5 deaths. I'm sure we talked about all of them, except one or two. I'm sure we talked about most of them. So please, all those causes of under 5 deaths, it's very, very, very important that we get them, because they are likely going to be the questions we are going to be asked. So we are going to use this outline. Next slide. Why is the slide looking too small? Okay, next slide. Yeah. So what is pneumonia? By way of definition, pneumonia refers to inflammation of the lung parenchyma. So anytime you hear pneumonia, it refers to inflammation of the lung parenchyma. And basically, we have several classifications for pneumonia. We have community-acquired pneumonia and we have hospital-acquired pneumonia. So hospital-acquired pneumonia is any pneumonia that is gotten on someone on admission, whereas community-acquired pneumonia is the pneumonia that is acquired in the community. So most at times when we say pneumonia, we are mostly referring to community-acquired pneumonia. Right? Next slide. So we have several definitions of pneumonia. Can either classify pneumonia based on the clinical diagnosis. And clinical diagnosis, it just means any child that has fever and lower chest injury. That is the basic definition for pneumonia. And why it is simplified is because we want to increase the coverage, the diagnosis of pneumonia. So the diagnosis of pneumonia, any child that has fever and lower chest injury is said to have pneumonia. Then based on chest x-ray, you can also classify pneumonia as either lobar pneumonia or bronchopneumonia. So bronchopneumonia is the type of pneumonia that is common in children. That is the type of pneumonia we find in children, whereas lobar pneumonia is seen in older children and in adults, but bronchopneumonia is seen in children and in elderly people. Then you can also use culture-proven pneumonia. So you can see Staph aureus pneumonia, pneumococcal pneumonia, streptococcal pneumonia, Haemophilus influenza pneumonia, based on the organism that is causing the pneumonia. Next slide. So we talked about this, that any child that has fever and lower chest indrawing, signs of parenchymal infiltration is termed as having pneumonia. But the gold standard is when there is inflammation of the lung parenchyma. That is the diagnosis of pneumonia. Next slide. Next slide. So pneumonia, we said any child that clinical diagnosis is any child with fever and lower chest indrawing. Then severe pneumonia, any child that has pneumonia. In addition, the child has any of this, has desaturation, has grunting. Grunting means there is severe respiratory distress. Then the child has features of hypoxia. That means features of encephalopathy, such as convulsion, irritability, reduced level of consciousness. All these will signify severe pneumonia. So any child that has, in addition, lower chest indrawing, in addition, he has any of this, you tag him as having severe pneumonia. Next slide. Yeah, so this is just giving us a guide as to the respiratory rate, because based on age, several age group, they have different respiratory rate. So you see there is difficulty with breathing in a less than 2-month-old when the respiratory rate is more than 260 breaths per minute. Then for those that are less than 1 year, you say there is tachypnea when it is more than 50. Then for those 1 to 5 years, when it's more than 40 breaths per minute. So it's important we know that. Then other features is you see flaring of the alar nasi and lower chest indrawing. All these signify signs of pneumonia. Next slide. Then, yeah, we've talked about this. Next slide. So what are the other things that can present with difficulty with breathing? Other conditions that can present with difficulty with breathing include bronchial asthma. So it's important you exclude bronchial asthma. Then acute bronchiolitis, which occasionally may be difficult, especially in infants, to differentiate it between pneumonia. So I'll be expecting somebody to ask how we differentiate the two. So maybe later, if anybody is curious, we'll try to answer how you can differentiate the two. Then laryngotracheal bronchitis can also present with respiratory distress. But by and large, pneumonia is commoner than most of these conditions. So anytime you see a child with fever and difficulty with breathing, your first differential should be pneumonia, but you can also consider other differentials like this. Next slide. So pneumonia is very common in children, but it's more common in neonates and those with severe malnutrition. So it affect at least 156 million new cases. So you can see it's actually very common, and majority is in Africa. So pneumonia, especially the period we are getting into, this cold weather, It's actually the period that is associated with very high incidence of pneumonia in children. Next slide. Next slide. So what are the risk factors for pneumonia? The risk factors for pneumonia, one, we said malnutrition. So children with malnutrition have increased risk for pneumonia. Then low birth weight babies also have increased risk for pneumonia. Then those that are not exclusively breastfed, it's also a risk factor for pneumonia. Then lack of measles immunization. So measles infection is a significant risk factor for pneumonia. And I remembered when we discussed measles, I told you that the commonest cause of death in children with measles is pneumonia. I remember I mentioned this. So measles infection is a risk factor for pneumonia, and measles can cause both. The measles virus itself can cause pneumonia, then they can also be a superimposed bacterial infection. Then another risk factor is when there is household air pollution. So especially in the urban areas, pneumonias are commoner than in the rural areas where we don't have so much pollution of the air. Then overcrowding is an important cause of pneumonia. So when there is most of the organisms are transmitted. So if there is overcrowding, one other, so it's also a risk factor for pneumonia. Then other, but not as strong as the other, is parental smoke. Also a risk factor for pneumonia in the children. Then deficiency, also a risk factor for pneumonia. Then it's also a risk factor for pneumonia. The reasons is aspiration pneumonia, and one of the reasons is those children that are force-fed, and it's quite common in children that whose mothers are not too well experienced. You see that they usually force feed those children. This usually leading to recurrent aspiration and subsequent pneumonia. Then those with some disease conditions such as congenital heart disease, sickle cell disease, and immunodeficiency states also are at risk for pneumonia. Next slide. Like we talked about mother's education in relation to force feeding and all that. Then daycare attendance is also a risk factor. Then outdoor air pollution is also a risk factor. Next slide. So other risk factors in the neonates is when there is premature rupture of the membranes. When the membranes rupture at least 18 hours before delivery is a risk factor for pneumonia. When there is low birth weight, preterm delivery, and lack of exclusive breastfeeding is also a risk factor for pneumonia. And when there is a concomitant disease such as the heart disease, it's also a risk factor for pneumonia. Next slide. Yeah, so pathophysiology, next slide. So basically the pathophysiologic mechanism is the same. The basic problem is when there is damage to the respiratory epithelium. So that will lead to inflammation, and inflammation is always associated with fluid, abnormal secretions, and fluid accumulation. So that will temper with gaseous exchange because of that inflammation, and that is the basic pathophysiology of pneumonia. Next slide. So the pathophysiologic mechanism also depends on the type of organism that is invaded. Next slide. So for strep pneumo, like we mentioned earlier, the basic problem is fluid exudation, inflammation with fluid exudation, and subsequently affecting gaseous exchange. But for staph aureus can cause what is called necrosis of the lung parenchyma. So it causes cavitation, and we see it as punctuate cavities, and subsequently this can cause pneumatoceles, empyema, right? So anytime you see pneumatocysts on X-ray, the possibility of Staph aureus is very high because Staph aureus is one of the highest that causes pneumatocysts in children with pneumonia. Next slide. Next slide. So we talked about, we have two forms of pneumonia. We said bronchopneumonia and lobar pneumonia. And I said earlier that bronchopneumonia is more common in those children under 5s because they are not able to contain the infection. So bronchopneumonia means widespread inflammation of the lung parenchyma. So there is widespread inflammation as against bronchopneumonia, where it causes, there is warning of the infection specific lobe of the lung. So it's very common in infants, young children, and the elderly. And the commonest organisms, there are three. They are strep pneumo, Haemophilus, and Staph aureus. Please and please, we have to remember these three organisms. Three common causes of bronchopneumonia: Staph aureus, strep pneumo, and Haemophilus influenza. These are the three commonest causes of bronchopneumonia in children. Next slide. So usually they may be preceding viral infections such as influenza and measles. And like I said earlier, aspiration of food, because in those children that are force-fed and because the feeding is not well established, very easily, these children aspirate the remnants of food, and that can cause pneumonia. Then irritant gases can also irritate the epithelium, and that predisposes to pneumonia. Next slide. So, but lobar pneumonia, strep pneumo is one of the commonest causes, and followed by Klebsiella, Haemophilus, and also Staph aureus. Next slide. So, basically, there are 4 stages of inflammation for lobar pneumonia. You have the stage of inflammation. That is the stage where you get exudation of fluid, neutrophils, and all these things. So there is so much inflammation in the lungs. That is the first stage, and that's the early stage where you have respiratory distress, difficulty with breathing, and all that. The next stage is because of this exudation of cells, where we have red blood cells, it causes what is called red hepatization. What red hepatization means? Next slide. Yeah, what red hepatization means is that the consistency of the lungs becomes similar to that of the liver. That is hepatization. It changes the consistency of the lungs. The lung is supposed to be smoother than that of the liver. So, but when there is inflammation, the consistency changes to similar to what you see in the liver. So that is what is the red hepatization. And the red is due to exudation of red blood cells. And the next stage is the gray hepatization. Gray hepatization means there's degradation of these red blood cells and subsequently change of color from red to now gray color. That's the gray hepatization we see. And the final stage is resolution, when there is resolution of this inflammation and these abnormal cells tends to get removed, and that child gets some improvement. Next slide. So you can see this is just a picture showing you the lungs looking similar to that of the liver, right? You can see this consistency is similar to that of the liver. And that's where we see hepatization. Hepatization is about consistency similar to that of the liver. Next slide. Next slide. Next slide. So clinical features, the cardinal feature for pneumonia is difficulty with breathing. That's the cardinal feature. So fast breathing is a significant marker for respiratory distress. So whether there is no fever or no fever, anytime you see a child with lower chest indwelling, the first thing you have to consider is pneumonia. But there are other differentials, especially in children. Foreign body aspiration is an important differential. A child can just pick something on the floor, put it in the mouth, and get to aspirate it. And that is a likely cause of sudden difficulty with breathing. Anytime you see a child and the mother tells you the difficulty with breathing started suddenly, it's very, very important you consider foreign body aspiration. Next slide. So other features include fever, crepitations. So you pick abnormal crackles, just similar to what you pick when you are squeezing a dried leaf, there are crackles. So you pick it on the chest of any child that has pneumonia. Next slide. So in newborns, you may present with non-specific features such as fever, hypothermia, poor feeding, abdominal distension. So the features are usually less specific for neonates than older children. Next slide. Next slide. We talked about this. Next slide. So the radiologic features we talked about, lobar pneumonia is restricted to a single lobe, whereas bronchopneumonia, you see patchy opacities widespread in the whole lung. Then interstitial pneumonias is just around the alveolar. So you see around the hilum, you see just streaks of inflammation in interstitial pneumonia. Next slide. Next slide. So these are the important differentials. Many other conditions can look like pneumonia. So you can have malaria, severe anemia, can present with respiratory distress. Those in heart failure from whatever cause can present with respiratory distress. Those with congenital heart disease, those with tuberculosis, those with foreign body aspiration, all these can present with respiratory. So they are important differentials. Next slide. So what are the complications of pneumonia? We have heart failure, is an acute complication. We have pleural effusions, can have pneumatocysts, pneumothorax, and pneumothorax, can have atelectasis, and it can also lead to septicemia. Next slide. And the chronic complications include lung abscess and bronchiectasis. Next slide. So investigation can do a chest X-ray, which may show whether it is lobar or bronchopneumonia, may also show the presence of complications. So if the child has pneumatocysts, you'll be able to see. If the child has pneumothorax, you'll be able to show. But there is no specific investigation that is specific for pneumonia. So if blood culture may be positive in some few percentage, then you can do rapid antigen test. You can do serology test. So you can take an aspirate, pharyngeal aspirate, similar to what you do in the COVID test. Right? Just take a pharyngeal aspirate, swab, and you do your serologies for antigen test for common causes of pneumonia. Next slide. So the best specimen, like we said, is nasopharyngeal specimen, right? But you can also take a gastric aspirate for pleural fluid. Next slide. So aspiration is not done to aspirate the lung, where the diagnosis so the best clinical diagnosis is still the most important. X-ray may be normal. We show features whether it is low. If there are complications, you will be able to see. Next slide. You can see there is look at the perihylum. So we say usually they are streaky inflammatory infiltrates. We don't have a pointer, but if you look at the left, there is significantly hazy. So we say there is infiltrate. So it's actually a sign of pneumonia in children. Cultural sensitivity is very low, just about 30%. That is why I said the most important. Any child with fever, cough, and lower chest likely pneumonia. Next slide. Next slide. Next slide. Next slide. Next slide. Just next slide. Next slide. Just go on to treatment. Yeah. So the treatment of choice antibiotics. And the first line antibiotics, depending on whether the pneumonia or is not severe. So those that don't have severe pneumonia, patient management. Those that have severe pneumonia, right? We said any child that has hypoxemia, other features of complication, marked respiratory distress, respiration, that is very sick. Except a child or the child is an infant. Any infant with pneumonia, you have to, except if there are features of severe pneumonia management. And the first line treatment is use of oral. That's the first line. For those with severe pneumonia, use of IV amoxicillin and gentamicin. And gentamicin for those with severe infection. Other modalities of treatment or management is need. So anytime the child has marked respiratory distress, you have to give oxygen. Respiratory rate, then you have to increase. So you need to give adequate hydration for the child, for those children. And other supportive management include temperature, manage the temperature. Then other drugs you can use include ceftriaxone. First line is amoxicillin and gentamicin. Next slide. Next. Yeah, we've talked about this oxygen and yeah, you counsel the parents. If the parents are small, there is environmental, you have to counsel the parents on the condition. Next slide. Yeah, so just take questions and comments. The things on the slides, we may not need them. So let's ask questions. Let's all unmute and ask questions.
So I have a question.
Yes.
The part where you said differences between pneumonia and was it asthma bronchiolitis, you said?
Yes.
Yeah, because I'd like to know the difference between the two.
So bronchiolitis is inflammation of the parenchyma, but it's caused by viral infections in on those infants less than 1. And the classical, like I said, is a viral infection. So the classical presentation as those with pneumonia, and they present with fever, then nasal discharge. The history subsequently nasal discharge, and before you know it, the child breathing. And the causes is, like I said, viruses. Common cause of bronchiolitis management is you use in steam inhalation. The major problem they have is excessive secretions. So you use steam inhalation, and not as toxic as a child with pneumonia. And that means you don't need to give any antibiotics, right? And when you said what you pick is rhonchi, you know the difference between rhonchi and crepitations, because so they cause obstruction of the airway, and that will prevent. But sometimes it's quite difficult to differentiate between bronchiolitis. It's also both inflammation. But if you are experienced, you may be able to bronchi as against crepitations. Even though in some cases of severe pneumonia, crepitations are commoner as against bronchi. I don't know if I've answered your question. Have I answered your question?
Yes, sir. Just to recap what you said in bronchiolitis, it's in infants less than 1 year. And the virus you said was respiratory syncytial virus, right?
Hello? Yes.
Yeah. What did you say the virus was? RSV.
Influenza virus.
Okay. And they present with fever, nasal discharge, and in severe cases, respiratory distress.
Yes, subsequently with
Okay, subsequently. And you said the treatment is mostly with steam inhalation because it's not as toxic as pneumonia.
yes.
And in
And you can use
auscultation, okay, you can also use steroids too. Okay.
like dexamethasone to reduce those inflammation.
Okay. And then you said on auscultation you find rhonchi, but it's very difficult to differentiate between that and pneumonia. Okay.
Any question?
Thank you.
So please, we should ask other questions.
Good evening, sir.
Good evening.
Sir, I have a question.
Go ahead.
Sir, please, what is different between pneumocystis pneumonia and bronchopneumonia?
Pneumocystic.
Yes, sir.
Okay. Cardiac pneumonia is a form of HIV patients. It's an organism that is called as pneumocystis. is seen in HIV pneumonia, because once we say pneumonia, it means inflammation of the lung. Is inflammation of the lung parenchyma, but it's in immunocompromised individuals. HIV patient, but it can be seen in other conditions with cancers, right? And the basic tetramethoxam. So that is why all those giving prophylactic tetramethoxam to prevent, right? And also those with conditions such as giving prophylactic pneumonia. Once you say pneumonia, it just means inflammation. It may be fungal, and even the pneumocystic. But when we are talking of pneumonia, and that is seen in all that you only see in immunocompromised individuals. I don't know if I've answered.
Yes, sir. Thank you, sir.
So, any other question? So, yeah, look on diabetes in children. Yeah. Well, I don't know. So, I'm sure medicine will meet diabetes O and G, where they talk about gestation in children, can also meet about management in surgery. It refers to a syndrome that results due to of insulin, metabolism of carbohydrate. Next slide. So we have diabetes. We have the type 2, and we have gestational. We know it's due to destruction of B cells, that deficiency of insulin. It needs exogenous insulin, and is the common worldwide, commonest. So anytime you see a child with diabetes, the possibility is likely type 1. It's due to resistance, insulin resistance. So there is the insulin is there, but there is resistance of the receptors to this insulin, or there is inadequate production of insulin. Previous slide, please. Yeah, then we have genetic defects. We have the neonatal diabetes and the maturity onset diabetes of the young. Then we have secondary diabetes, any condition in which there is disease of the exocrine pancreas, right? Any disease of the pancreas can present with diabetes. Then drug-induced, drugs such as steroids can also cause diabetes. So it's a cause of diabetes. Then the last is the gestational diabetes. Next slide. So we said type 1 accounts for more than 90% in children. Occasionally, you can find type 2 diabetes and can find neonatal diabetes. Then also there is the maturity onset diabetes of the young. Then you can find secondary diabetes in those that are on steroids and other conditions. Next slide. So type 1, we said, accounts for almost all diabetes. It is an autoimmune condition in which there is destruction of the type 2, the beta cells, right? And it's usually triggered by environmental factors in genetically susceptible individuals. Next slide. So it can have an acute onset and it can occur at any age, but usually occurs in children. And in some children, the first presentation is with DKA, diabetic ketoacidosis, right? So they will not have any features of polyuria, polydipsia, because usually most children, you need a careful parent to be able to observe that this child is having polyuria. Most parents don't recognize that the child is having any change in urine. Next slide. Next slide. Next slide. So the classical symptoms said polyuria, polydipsia, and weight loss. And like I said, it's difficult. You need a very observant parent to recognize polyuria in children. Then sometimes they can present with DKE. Then it may be accidental. The child is taken to the hospital for another condition and they just test the glucose and they find it's very high. And nowadays, in most of the schools nowadays that use screening, preschool screening, the child is taken to school for an investigation and they find that the child has glucose in the urine. Usually it's taken to school and they ask them to do urine test. And they do the urine test, they find glucose in the urine, and from there they make a diagnosis. Then they can also present with anorexia nervosa-like illness. So the child presents with excessive wasting. Excessive weight loss can also be a presentation of diabetes. Next slide. So the risk factors, there's a combination of genetic and environmental factors. Type 1 is caused by immune destruction of the insulin-producing cells, and there are some presence of antibodies that increase the risk, such as GAD65, ICAR, and the IAE. All these are known to cause the risk factor for development of diabetes. Next slide. Then in addition, those children that are first degree relatives with someone that has type 1 diabetes, they have increased risk of development of diabetes. And in general, 70% of people with new onset will have positive antibody for diabetes in them. Next slide. So how do you diagnose diabetes? Using the fasting blood sugar. Fasting blood sugar of more than 7 millimoles per liter is used to diagnose diabetes, or you can use the random blood glucose of more than 11.1 millimoles per liter, or anytime you have your glycated hemoglobin of more than 6.5%, you can use any of this, either the fasting blood sugar of more than 7 millimoles per liter, or random blood sugar stroke 2 hours postprandial glucose of more than 11.1 milligram per dl, or you use your glycated hemoglobin of more than 6.5%. So any of this is used to diagnose diabetes. Next slide. Yeah, so I've talked about this. So type 2 used to occur mainly in adults previously, but now we are having a little change in lifestyle as we have a lot of obese children. So we are now seeing more of type 2 diabetes also occurring in children, because there is a lot of inactivity in children. There are no playgrounds in some schools, so children don't get to play. And the modification in lifestyle, children now eat shawarma, pizza, and all those things that have changed the lifestyle. So we have a lot of overweight children that is predisposing them to type 2 diabetes. And most children with type 2 diabetes, they have what is called insulin resistance. We have the features of insulin resistance that we're going to discuss later, and usually a family history of type 2 diabetes. Next slide. So symptoms, some children with type 2 may not show any symptoms, but sometimes they may present with similar features of type 1, so polyuria, polydipsia, and weight loss. Then they may present with excessive thirst or nausea. They may also present with weight loss, poor vision, frequent and recurrent infection. Can also present with slow or wound healing. Slow wound healing can also be a sign of type 2 diabetes. They present with burning in. Next slide. So they present with pain or micturition. Then they can also be accidental diagnosis. They present with other features and they get to be diagnosed. Next slide. So physical examination may show signs of acanthosis nigricans, which is a sign of insulin resistance. So they have this darkish discoloration around the armpits, right? And in girls, they can have features of polycystic ovarian syndrome, right? In which they have excessive hair, they have obesity, they have oligo problems with menstruation. So they have oligomenorrhea, so infrequent menstruation. So all these are signs of insulin resistance. Next slide. So complications of diabetes, the acute complications of diabetic ketoacidosis and hypoglycemia. And the long-term or chronic complications include retinopathy, neuropathy, nephropathy, ischemic heart disease, and stroke. Next slide. So the main goals of management of diabetes is to achieve almost close to normal metabolic control as much as possible, and to avoid complications such as hypoglycemia and DKA. Then to minimize chronic complications, then you assist the child to live as normal as possible. You can imagine a child, you tell him not to take sugar, you tell the child not to take biscuits, tell the child not to take chocolate, and the child has to take injections every day. So you have to help the child and the family because it's traumatic. Understand? The whole family diet may have to be changed because of just one child. So you have to assist that family, then achieve normal psychological maturity and independence. Usually, all adolescents that are on drugs, they are very difficult to manage. Those children with epilepsy, sickle cell anemia, HIV, because the child feels, why will I take drugs every day? Feels, why will I have to swallow every day? And the child goes to school, he sees another child taking chocolate, and you tell him he cannot take chocolate. So that affects their psychological well-being. So you need to manage that also. Next slide. So the basic management is one, insulin administration, which is the key management. We said in type 1, usually there is no insulin. So it's a must. You must give them insulin. That's the only way they survive. Then nutritional management is very, very, very important. So you have to regulate what the child eats. Usually you have to avoid those high calorie diets. So child avoids added sugars, avoid high calorie feed as much as is possible. Then increase physical activity. So the child that is inactive, you have to encourage a little sport, encourage the child. Then blood testing, blood glucose testing. So it's advocated now that we have glucometers. You counsel the parents on use management of the blood glucose monitoring. Then you have to avoid severe hypoglycemia. Usually, the common causes of hypoglycemia is overzealousness on the part of the caregivers. They want the glucose to come back to normal as soon as possible. So they do all sorts of overzealous things. If it's insulin, they will tend to increase the dose of insulin because they want the glucose to come down. And you have to counsel them that hypoglycemia is a is an important risk factor. In fact, it's more serious than hyperglycemia. So they have to avoid overzealousness. Then they have to avoid DKE, right? And you have to maintain normal growth and development. Next slide. So education, tell them about diet and meal planning, then monitoring. They have to be doing glycated hemoglobin at least every 3 months. Then home regular blood glucose monitoring is very important, at least even if they can be doing once weekly. Then home urine ketone testing in those that suspect DKE. You should be able to check the urine to see if there are ketones. You know that there is likely DKE and they rush to the hospital. Next slide. So you have to educate the parents and the caregivers on diabetes. Let them know what diabetes is. It's key, is the most important aspect. If you don't educate the parents, you have missed. There's no way you're going to win, because once you start your insulin, somebody somewhere will come and mislead them that he has the drug treatment for insulin. He tells them to take Zogali every day, and the child is free of insulin. So the parents keep going round and round looking for remedy, because what our people don't want is to tell them that the child is never going to become normal. So people don't want management, they want complete cure. So you have to educate them that there is no complete cure for diabetes, and that the major problem is insulin deficiency. And for this child to survive, he has to get insulin. If you don't do that, a malam somewhere will tell them that they take Zogali every day with another concoction. The child is free of diabetes, and before you know it, the child is brought in decay and subsequently die. So education about the disease is the most important. Two, you have to educate them about insulin. What is insulin? How is it given? How is it stored? Because we all know that insulin requires a relatively cold environment. So it's advocated that you keep it in the fridge. So for a child that is living in the rural areas, you have to counsel them on how to keep it. So usually we ask them to get places where they keep this randa. I don't know how you call it randa in English. So where they keep randa, usually you find in rural areas where they put randa is usually relatively cool. So we ask them to keep it around that area, so to be able to be kept active for a while, right? Then you have to tell them how to give the insulin and what are the side effects of the insulin administration. And you have to tell them about life-saving skills in cases the child develops features of hypoglycemia, what they should do. So you ask them to always get sugar cubes or soft drinks, right? So that as soon as the child begins to have some features of hypoglycemia, excessive hunger, sweating, dizziness, that they should quickly give the child. Then you have to tell them how to recognize hypoglycemia and decay. Then you have to plan the meal of the child and also seek the management. Next slide. So, but for type 2, the cornerstone is healthy eating, portion control, because most of these children are obese. They don't know when to stop eating. So, but you have to let the parents know that the child's diet has to be regulated, then increase physical activity. Sometimes you may have to give normal oral hypoglycemics, or you may have to give insulin. Next slide. Next slide. So we all know how insulin functions. Next slide. We're not going to talk about insulin. So we have several types of insulin. We have the short-acting insulin, we have the intermediate-acting, and the long-acting insulin. So depending on what you are going to manage, we use a combination of intermediate-acting and short-acting, or intermediate-acting and long-acting insulin, or short-acting and long-acting insulin, right? So depending on type of management, there are several regimens of administration. Next slide. So adverse effects of insulin can have hypoglycemia, can have lipoatrophy, can have obesity, can lead to insulin allergy, can lead to antibodies, insulin antibodies, and insulin-induced edema. Next slide. So the practical problems is non-availability. So those in rural areas, you may find it difficult to get the insulin. Its injection sites is also a problem, and the technique. Then storage, like I mentioned, is also a problem. Cool. The recognition of hypoglycemia is a problem. Next slide. So exercise, you counsel the parent on exercise. The child needs moderate exercise. But if there is severe exercise, may predispose the child to developing hypoglycemia. So you have to warn the child from strenuous severe exercise. Just moderate, mild to moderate exercise. Next slide. Then monitoring, you monitor the compliance. So you check the glucose records, you check the home blood glucose tests, then hemoglobin A1C, that's glycated hemoglobin. You monitor the growth and development of the child. Next slide. Next slide. Next slide. So we are going to quickly talk about management of DKA. Next slide. So the cardinal features of DKA is hyperglycemia, blood glucose of more than 11.1 millimole per liter, then presence of ketonuria of more than 5 and ketonemia of more than 3. Then when there is acidosis, venous pH of more than less than 7.3, or acidosis bicarbonate of less than 15. So anytime you see these three features, the child is said to have DKA in the presence of diabetes. They are classified as either mild when the bicarbonate is less than 15, moderate when it's less than 10, and severe when it's less than 5. Next slide. Next slide. So the goals of management, the first is to correct dehydration, then correct the acidosis and reverse ketosis, restore blood glucose to near normal, avoid complications, and treat the precipitating cause. Next slide. So it's actually an emergency. So anytime you bring a child with suspected DKA, you have to take a brief history. In children, the common presentation is there's excessive urination, then the child is having abdominal pain and vomiting. That's the classical presentation. Abdominal pain, vomiting, and increased urination. So, and next is you have to quickly weigh the child and assess the degree of dehydration. So most children with DKA have severe dehydration. Then you assess the level of consciousness of the child and you do a biochemical assessment. Next slide. Then you take your samples, include blood glucose, electrolyte, urea, and creatinine. You check the pH, you check for infection because the common precipitants for DKA is infection. So you have to rule out infection. Next slide. You have to take the urine for presence of ketones, right? So you have to also do blood culture. Next slide. Then you have to secure his airway, make sure the child is breathing. You commence IV fluid. Next slide. You give oxygen and you commence antibiotics as soon as possible. Next slide. Yeah, so the most important is fluid management. So anytime the child presents with DKA, like I said, most at times we have severe dehydration, right? So you assume the child has lost 10% of his weight. Next slide. Next slide. Yeah, next slide. Yeah, so as soon as the child comes, you give him anti-shock, 10 mils per kg per hour. We've talked about anti-shock, how to give, we said you give 20 to 30 mils per kg. But in those with DKE, because one of the commonest complications of DKE management is cerebral edema. So we don't give 20 to 30 mils per kg, we give 10 mils per kg hourly. But the first 2 hours we give and we access the child. Right? If the child is still in shock, you have to repeat the fluid. Then the subsequent management, you correct it over 48 hours. You remember when we were talking about dehydration, we said you correct it over 46 hours. But for those with DKE, because of risk of cerebral edema, you correct it over 48 hours, right? And any fluid that is given outside this should be added to this calculation because you don't want to give the child excess fluid to tilt him to cerebral edema because it's the commonest cause of death. Then you don't give more than 2 times the child's maintenance at the same time. Next slide. So this is just giving us the maintenance fluid for children with DKE. So anytime the child is 2 years, 0 to 2 years, his maintenance per day is 80 mils per kg per day. In time the child is between 3 to 5 years is 70. Child that is more than 15 years, his maintenance is 30 mils per kg per day. Next slide. So this is just giving us how to correct the fluid, right? We said you correct it over 48 hours. So you add the maintenance and your resuscitation fluid plus his deficits based on what we said, and you correct it over 48 hours. Next slide. Then insulin therapy, you have to start insulin. You start with short-acting insulin IV at 0.1 unit per kg per hour, and you subsequently convert into subcutaneous insulin when the child is out of DKA. Next slide. Next slide. Next slide. Next slide. Yeah, so once the child is making urine, you now have to add potassium, because commonly all children with DKA have potassium deficit. So you have to give potassium to all those children with DKA. Next slide. Next slide. Next slide. Next slide. Next slide. So usually with your commencement of insulin, there is reversal of acidosis, so there is no need to give bicarbonate. But in some cases, you may have to give bicarbonate in those that have severe acidosis. Next slide. Next slide. Next slide. Next slide. So monitoring, you have to monitor the blood pressure, respiratory rate, heart rate, level of consciousness, the blood glucose, ketones, and electrolytes, urea, and creatinine. Next slide. So what are the complications? Complications can have inadequate rehydration, can have hypoglycemia if you are overzealous with insulin. Then hypokalemia is a significant problem. Then hypophosphatemia can be seen. And also cerebral edema is the commonest cause of death. So any child you are managing for decay and the child begins to convulse, it is cerebral edema until proven otherwise. Next slide. So, questions? Please, let's ask questions.
I have a question. Two questions actually.
Okay, go ahead.
So I've come across like some questions that they were asking, like they were asking like what if you were to diagnose diabetes, and the options were fasting blood glucose, oral glucose tolerance test, HbA1c, and random blood glucose. And if I was to choose, sometimes if I choose fasting blood sugar, they tell me is the other one. So I want to know, like, what is the most specific or gold standard for diagnosing diabetes? That's the first question. And the second question is there like a total fluid we're supposed to give patients with DKA or even with HHS, or is it just based on the severity of dehydration? We'll not calculate from there.
Yes, so based on your first question, the most important modality of diagnosing diabetes is your fasting blood sugar in addition to the signs and symptoms. So any child that has signs and symptoms of diabetes, you do fasting blood sugar is more than 7 millimole per liter, it is diabetes. Is that clear? So you need to do 2 hours postprandial in those that you are having diagnostic challenge. For example, gestational diabetes, you have challenge in diagnosing them, then that is when you do your 2 hours postprandial challenge. So it's just a challenge to see. So you have problem. Then glycated hemoglobin most at times is used for monitoring, not diagnosing, but you can also use it to diagnose. So it's used for monitoring, because what glycated hemoglobin tells you, it measures the glucose attached to red blood cells. So it tells you the long term, at least 3 months, because half-life of red blood cells is 120 days, right? So it tells you the 3 months control of the child. So most at times it is used for monitoring, not diagnosis, but you can also use it to diagnose. So, but the best diagnosis is use of fasting blood sugar in addition to clinical signs and symptoms. That is diagnosis of diabetes. I don't know if I've answered your first question. The second
Yes, you have.
question.
Thank you.
Yeah?
Yes, thank you.
Okay. So the second question, like I said, you add the deficit of the child based on his degree of dehydration. So if the child you feel is moderately dehydrated, the amount of fluid you are going to use, is at least we said 5% of his body weight he has lost, so 50 mils per kg. Well, if the child is severely dehydrated, it's 100 mils per kg, right? Then you add that to his maintenance and you spread it over 24 hours. Is that clear?
Yes, sir, it is. Thank you.
So that is how you do it. And the maintenance is not the normal maintenance we know. That's why I gave you that table there on the maintenance fluid. Mils per kg use. Right? For those less than 2 years, that's when you give 80 mils per kg. Right? Those 3 to 5, you give 70. It tends to reduce as they increase. I don't know if I've answered your question.
Yes, you have. Thank you very much.
So, next question. Next question. Questions? So, there are no questions again. So I don't know if we can take one more, or time for prayers now is just 15 minutes left. So what do we do? Can we take one more presentation, or what do we do? I need to hear from you guys.
Maybe we can take neuroblastoma because it's very short.
So go ahead and share it. So next slide. So next slide. So neuroblastoma is also called Wilms tumor, and it's one of the most common malignant neoplasm affecting the urinary tract in children. It's an embryonal tumor. So anytime you hear embryonal, you hear it is called blastoma. So we have nephroblastoma, neuroblastoma, hepatoblastoma, retinoblastoma. So anytime you hear blastoma, it means it's an embryonal tumor. And what is common about embryonal tumors is commoner in younger children, less than 2 years of age, because usually the problem starts as mostly there's some genetic components to it. So embryonal tumors are commoner in children less than 2 years of age, right? So there is presence of all 3 cell lines of cell types of the kidneys. We have the blast cells, stromal cells, and epithelial cells. All can be affected. Next slide. Represent about 6% of all childhood malignancies. Reported incidence about 8 cases per million children per year, and the peak incidence is 2 to 3 years, like we talked about, 2 to 3 years, and more than 75% are seen before 5 years of age. So you rarely find nephroblastoma in children more than 5 years, usually less than 2 to 3 years, and there is no male or female preponderance. Similar incidence to male and female. Next slide. So the main cause is not known, but there are some genetic defects that are predisposes to development of Wilms tumor. We have 95% it is sporadic, and in 1 to 2% it is familial, right? Then bilateral in 5 to 10%. So 2% is associated with some syndromes. We have the WAGR syndrome, in which there is Wilms tumor, aniridia, genitourinary malformations, and mental retardation. Then the Burkitt-Wiedermann syndrome is relatively common, which is associated with omphalocele, macroglosia, and visceromegaly, then Wilms tumor. Then the Dennis-Drash syndrome and the Palman syndrome. All these are relatively, especially the Burkitt-Wiedermann is relatively common. Next slide. So children with such syndrome should be screened at least every 6 months till they are 8 years for risk of development of Wilms tumor. Then the genes that are associated include the Wilms tumor gene 1 and Wilms tumor gene 2. Next slide. So Wilms tumor is sharply demarcated and encapsulated. Usually, so that is why most at times Wilms tumor, the surgeons manage Wilms tumor because it is highly resectable. Because it is highly encapsulated, so usually it's a surgical management because most at times it is resectable. And microscopically, you can find all the 3 components: blastema, tubules, and stroma. Right? Next slide. So staging is used of national Wilms tumor staging. Stage 1 is when the tumor is limited to the kidneys and completely resectable. Stage 2, when it extends beyond the kidneys but can still resect. Then stage 3, when there is non-hematogenous tumor. Stage 4 is when there is hematogenous metastasis, and stage 5 when there is bilateral tumor. Next slide. The diagnosis is based on history. Usually a child presenting with abdominal mass, classical history. And other findings include abdominal pain, fever, weight loss, hematuria. Then they may present with acute abdomen when there is rupture. The physical examination is be able to palpate a mass in the abdomen, typically that you cannot go above it and usually does not cross the midline. Then there may be hypertension, right, in those child. Then there may be other features. Investigation is ultrasound scan, the simplest investigation. And IVU is very, very important diagnostic investigation, especially to differentiate between neuroblastoma and nephroblastoma. Then the CT scan is also an important modality, chest X-ray, then other investigations such as U&E, full blood count. But in AKTH now, we use what is called CT-IVU. It has been shown to be more effective in the diagnosis. When you combine IVU with CT scan, known as CT-IVU, it improves the diagnosis of both Wilms tumor and neuroblastoma. Next slide. So treatment is surgical excision. Then you can do post-operative radiotherapy and chemotherapy. Right? So surgery is the mainstay of management. So then you can add adjuvant chemotherapy. Next slide. Then radiotherapy can be done based on the degree of malignancy. Next slide. So we'll now talk about the neuroblastoma. It's a tumor of the neural crest cells. It's also an embryonal tumor. So commonly children less than 2 years of age, and it arises from the adrenal or sympathetic ganglia. So from the neck up to the pelvis, it can arise anywhere. And it's the most common solid tumor seen in children. And there is a possibility for spontaneous regression. There is, if you come to the staging, we have the 4S type, which can regress spontaneously. Incidence about 1 in 8,000 to 10,000. 50% of cases are seen in children less than 2 years, and it's more common in males than in females. Next slide. So 75% are retroperitoneal, 50% affect the adrenal medulla, and 25% paraspinal, and 20% in the posterior mediastinum and 5% in the head and neck. And microscopically, they present as small round cell tumors. So there are many other tumors that are small round cell tumors. We have many of them, right? So this is one of them, neuroblastoma. Others are retinoblastoma. They present as small round cell tumors. So there are other tumors we need to know that are small round cell. But I don't think anybody is going to ask you about that. Next slide. Staging is using the Evans staging, right? So stage 1, when the tumor is confined to the organ of origin. In stage 2, when it has gone beyond the organ of origin but does not cross the midline. In stage 3, when it extends beyond the midline. Stage 4, when there is distant metastasis. Then stage 4S is same as 1 and 2, but with involvement of the kidneys, the livers, and the bone marrow. Next slide. So the cause is unknown, but there are some mutations in some genes that increases the risk of development of neuroblastoma, such as the 1p36 and the mutation in 14q. Next slide. Next. So diagnosis at presentation may be due to the primary tumor or metastasis. The common presentation is abdominal mass, then weight loss, failure to thrive, and anemia. And other features include respiratory distress, dysphagia, paraplegia, Horner syndrome, hypertension, dancing eye syndrome, and panda eye. So the reason for this symptom is due to because what this tumor release, the major function of the adrenal medulla is to release the catecholamines, right? So it releases, because of the release of these catecholamines in excess and their byproducts, that is what causes these features we are seeing, this dysphagia, paraplegia, Horner syndrome. So as a result of excess catecholamines. Investigation similar to that of neuroblastoma, you do plain abdominal x-ray, ultrasound, IVU, CT scan, you can do bone scan, then you can do urine chemistry, which you see mandelic acid and vinyl mandelic acid. So these are byproducts of the breakdown of catecholamines, and there is screening test for neuroblastoma, the presence of HMA and VMA, right? Then you can do your blood chemistry. Then you can do bone marrow aspiration. So neuroblastoma is one malignancy that can be diagnosed from bone marrow aspiration because commonly it goes to the bone. Next slide. Yeah, this is an eye view. It's not clear, so just move to the next slide. The tumor markers, we talked about VMA, vinyl mandelic acid, and vinyl mandelic acid and homovanillic acid, then lactate dehydrogenase, serum ferritin. All these are markers of the tumor. Next slide. Treatment depends on the stage. Localized tumors are best managed with surgeries. So partial resection in those that are not completely resectable. Then you can use neoadjuvant chemotherapy, such as using cyclophosphamide, doxorubicin, vincristine, and cisplatin. And you can use radiotherapy and immunotherapy. Next slide. So outcome, stage 1, more than 90% survive 5 years, and stage 4S, you can see 70% because it can regress spontaneously. Next slide. So, questions?
Question is just 1 or 2 questions really. For the
Yeah.
diagnosis, right, of nephroblastoma, are we supposed to know like what are the features that we'll find on ultrasound and IVU?
No, you are not expected. So, and it's more of pathology. You see, for undergraduate, usually what they are more worried about is the presentation. Understand how did you present? Just basic, basic. I don't think nobody will ask you. I don't think it's too much. They're not likely to ask.
Thank you.
So, questions? Questions?
Oh, one more. I just remembered. Is there any like prognosis between for nephroblastoma and neuroblastoma?
Is there any what?
The prognosis. What's the prognosis for nephroblastoma and neuroblastoma?
Prognosis depends on the stage now. All cancers depend on the stage they are. So you can't just see what is the prognosis of this one or this one. Depends on the stage. But for some selected few cancers, once you see them, you know that the prognosis is poor. Some, like hepatocellular carcinoma, cancer of the head of pancreas, once they appear, you know the person is unlikely to live more than 6 months, right? But most other cancers depend on the stage. But some cancers are more aggressive than others. But generally,
Okay, thank you.
yeah, next slide. Next question. Questions? Questions? Yeah, so we call it a day. How many lectures do we have left?
Okay, we have currently we did congenital heart disease, but we haven't done what's it called? Acute leukemia. And have we done? We've done nephrotic syndrome, I believe. Yeah, so it's just oh no, we haven't done nephrotic syndrome. So just these two topics remain.
No, we did nephrotic syndrome.
Okay, we did nephrotic. So it's just acute leukemia. That's all.
Okay. So when do we take it?
That's right. That's just, I guess, tomorrow. I think it would be best to discuss with Dr. Ben. Depending on the schedule.
So no problem. Discuss so we get a time and take it. Huh?
Okay, thank you.
So thank you all for your time.
Thank you, sir.